Welcome to the Future of Dermatology Podcast. I'm your host, Dr. Farah Kamangar, board-certified dermatologist. Along with being a dermatologist and the host of this podcast, I am also the president of the San Francisco Dermatological Society, which is composed of dermatologists who practice in the San Francisco Bay Area. Every year, we hold our annual SF Derm meeting, and this year we gathered our guests at the Ritz-Carlton in Half Moon Bay. From engaging sessions to incredible food and even a round of golf, SF Derm 2024 was a huge success. Continue listening to hear thought-provoking conversations from our incredible dermatologists who presented on matters that answer your dermatology questions, align with our goals, and provide insight to the future of dermatology.
These are truncated replays from our original recorded sessions. Join us next year to get the full impact of the SF Derm experience.
So we're going to talk about urticaria, and what I hear from a lot of dermatologists is that this is one of those disorders that you kind of hate to see come in the office, but actually there's a lot of really exciting things to talk about with urticaria, so hopefully I'll make it more interesting to you here. So these are my conflicts. I will note one thing, that I am a member of the International Urticaria Guidelines. I'm on the guidelines group and the work group, so those are being revised actually here in December coming up in Berlin, so a lot coming in this area. So I want to just talk a little bit about urticaria in terms of what is urticaria, because I think there's a lot of confusion. I'll get individuals that will ask me about cases, but they make it a little bit confusing. I just want to go back very high level. So when we're talking about urticaria, we haven't defined it yet. So the most important definition for urticaria is actually duration. So we're talking about duration less than 6 weeks is acute, greater than 6 weeks. Most of the cases that we're going to see in the dermatology clinic are going to be acute urticaria. So these are patients that are greater than 6 weeks. Acute and chronic, totally different in terms of the etiology. So we want to kind of highlight that piece. And then when we're talking about that chronic group, the greater than 6 weeks, we have two subsets. We have those that have a specific trigger. Those are the physical urticarias or the inducible urticarias. This is as simple as it sounds. This is something that's clearly associated. Pressure, heat, cold, for example. And that's very different from the 80% that we're going to talk about really in the chronic urticaria, the CSU. Why spontaneous? We used to call it idiopathic urticaria because these don't have triggers. So it's offset by the fact that the physical or inducible have a clear cause. One point to bring up here is that sometimes we talk about a wheal or a hive as if it's a primary skin lesion, but it's really not a primary skin lesion. So I want to highlight that by some pictures. But the key feature of urticaria, which makes it pretty easy to differentiate from virtually everything else you'll see on this long list of differential, most of those things that are in the differential don't have transient lesions. So one of the key things is isolating a single lesion and asking those patients if it lasts less than 24 hours. And most patients will say, if you ask them how long does one, they'll say, oh, I've had this for months. If you say, this one on your arm, just that one, how long does it last? They'll say, oh, hours. You can usually tease it out. So patients have to be coached here a little bit. And one important point is that CSU patients or urticaria patients can have angioedema, and angioedema can last up to 72 hours. So it's different than the 24-hour cutoff that we talk about for wheals. And this is why we're talking about it as not a primary lesion. Look at all the heterogeneity. So you can see the targetoid lesions. These are the typical wheals. Hard to see the erythema and skin of color. This is a patient I saw actually here in California, this kind of beautiful polycyclic arcuate lesions, and then angioedema, very common on the hands and feet or also on the face. So you're not required to have a diagnosis of angioedema, but about a third of patients have wheals and angioedema. And one point I'll make with the angioedema is that it rarely progresses to anaphylaxis, which is the real concern, and that's usually not the case. When we're talking about acute versus chronic, I won't spend a lot of time here, but the acute cases are typically self-limiting, often kids, usually less than 5 years old, usually go about 1 to 2 weeks. And they're all the common, we talk about like the 5 I's, like infections, injections, immunizations, inhalations, a lot of the causes there. And so mostly self-limiting. But what I want to highlight in this table here, if you look at this table too, the proportion of patients in remission. So this is calculating how many patients over a period of time develop complete remission. And if you look here at the 5 and 10 years, only a third of patients are developing spontaneous remission after 5 years. And if you look here in 10 years, it means 51%. The majority of patients with chronic urticaria actually have disease out at 10 years. And so 15 years ago, when I was a second-year medical student, I developed cold urticaria. So when I would walk in from the cold, I had the inducible type. So that's 15 years ago. So I still have chronic urticaria. So when we talk to these patients, we want to highlight the fact that this really is a chronic disease, and most of the CSU patients have disease, the vast majority for longer than 10 years. So really important when you talk about patients, when they say, how long am I going to have hives? We have no idea, but by probability, you're likely going to have it for well over 5 to 10 years, and some have it for a lifetime. Very, very different from acute urticaria. And about a third of patients with acute urticaria go on to develop chronic. Now, if you look at the inducible, they even have longer. So for me with cold urticaria, the likelihood that I'd have chronic disease is even higher. So the inducible urticarias tend to be a little bit more recalcitrant. So if you see those patients, you want to say, it's likely going to be chronic, but even longer than CSU, for example. So what's the driver of the mast cell or of urticaria here? And we're really talking about the mast cell. So if you were here for my earlier talk with Dupixent, we were talking about type 2 inflammation. So when we're talking about eczema or psoriasis, we're talking about the T cell in the immune system. So a very different cell type. We're talking about the mast cell here. So completely different cell, not the T cell. It's going to be the center of this disease. So mast cell disorders, this is going to fall under one of those. These are mast cells where they're the primary source of the cytokines and the signals driving urticaria. And so activation, we're going to talk about. Degranulation is when they release the proteins that are going to drive the hives. So that's going to be important. And most of the mast cells, when they get activated, you can see there's a lot of receptors here. But the most important receptor is the high affinity IgE receptor. And I'm going to show you some specific mechanisms. So when we think about urticaria, I want you to think about the mast cell being activated, and then all the proteins that get released by the mast cell are going to drive this disease. And there's pretty good data that other cytokines, including type 2 inflammation, which we just talked about earlier, so the cytokines like IL-4, 13, IL-31, these are going to help support the mast cell in causing the symptoms that we see in urticaria. So most of the mechanisms in acute and inducible urticaria, we don't really have a good understanding of it. We know there are risk factors like ingestions, medications, etc. for acute urticaria. We don't know exactly what causes urticaria. But in CSU, we actually have some very specific mechanisms. This will make sense why type 2 inflammation plays a role. So this is the mast cell here, and type 1 autoimmunity. So I want you to try to burn these in your mind a little bit. Type 1 autoimmunity is IgE dependent, meaning that it requires IgE. So type 1 immunity here, you can see there's IgE. The little comma shape here, this is the high affinity IgE receptor. The IgE is bound to the mast cell, and they start to bind autoallergens. So this could be double-stranded DNA, this could be thyroperoxidase, but IgE bound on the mast cell activates the mast cell. So this cross-linking activates the mast cell, which is going to lead to these changes, which is the vasodilation, the vascular leakage, that's the swelling, right? Hives under the skin are really just swelling under the skin. There's no surface changes, nothing in the epidermis. So this is an example where type 1 immunity is tied to the IgE antibody, and I'll show you why that's going to be important. The other mechanism, though, is IgG, so not IgE. So there's IgE urticaria and there's IgG. So IgG can bind directly to the high affinity receptor. It can activate the receptor, activate the mast cell, or it can bind to the IgE antibodies and then cross-link it, very similar to this autoantigen. So these are two very specific mechanisms. So we've learned the mast cell is central, IgG and IgE antibodies can contribute to disease, and that's where type 2 inflammation is going to be really key. These patients tend to have a lot of comorbidities. You can see the highest number, thyroid autoimmunity. This always comes up when patients or other clinicians will say, do you check thyroid antibodies, for example? Why do we check it? We don't check it because the thyroid's going to cause urticaria. We check it because if you have urticaria, you're at high risk for other things. So the answer is, if you see an urticaria patient, there's no reason to do a bunch of lab tests. You're going to do lab tests if they have symptoms of hypothyroidism, for example, because lab tests aren't going to change what we're going to do. So just note that autoimmunity is sort of a theme here. Thyroid autoimmunity is the most common. We only check it if there are symptoms, not because we need to, but we're trying to screen patients that might have thyroid disease they didn't know they had. So we're going to screen them based on symptoms. Twice as common in women compared to men. So you're starting to see this story. Antibodies, females, autoimmunity, that's a story that makes sense, right? So that's why we start to see higher rates of autoimmunity in our female patients, because we know they're already prone to autoimmunity, increased antibodies. So IgG, IgE is what we're talking about in this. And this gets back to sort of this question, right? So urticaria is a clinical diagnosis. Most of the time we can make this through my chart messages or a quick phone call. Seconds, you can walk into a room and say, this is urticaria. So rely on that. That's important. If you're not sure, circle an individual lesion. Ask them how long that lasts. If it lasts less than 24 hours, very high likelihood this is urticaria. We don't really have other lab testing. Why? The biopsies are non-specific. Lab tests, there's no specific biomarker. And we really only check thyroid or other markers if there's concern for symptoms, right? So if somebody has, gluten insensitivity, for example, or symptoms that suggest that, we might do the testing. But there's no standard laboratory tests that are required, which is really important. And I think really interestingly, actually IgE, we used to think that maybe this is a biomarker of disease, but actually it doesn't really correlate with disease severity or even treatment response. And so it's quite interesting when you start to look at that. The argues that allergists will check this all the time. It really doesn't change what we're going to do with these patients. So, we really just kind of push against that. Now, lots of ways to activate the mast cell. We talked about one really clear one, which is the high affinity IgE receptor, activating it with the antibodies. But there's all these other receptors. And that's why this whole area in urticaria is really blowing up, because there's all these other ways that we can block activation of the mast cell. So now we're just trying to tease out what are some of these other mechanisms. So I'm going to kind of give you some of the treatment landscape, because there's a couple of big therapies that are coming that are really transforming how we manage these patients. And the reason that we're talking about this is because about 50% of patients who go on high dose antihistamines don't get better. So most of the protocol, I think right out of the gates, if you're treating patients with monotherapy, just one dose a day, the urticaria guidelines, both the Quad A and the international guidelines, advise you to go up to 4-fold dosing as tolerated. So across the board, right out of the gates, when you see these patients, start them on 1, teach them how to go up to 4. You don't want to see them back until they've at least gone to 4, right? But know that about 50% of our patients actually have an inadequate response. So I just give a sheet to patients and say, this is how you get from 1 to 4. If you're not tolerating it, tell me. We'll note it as an intolerance. We're going to go on to the next step, which is really looking at systemic therapies. So don't get hung up on antihistamines. Some of the insurers might make you jump through like leukotriene antagonists, things like that. But for the most part, if people don't respond to one antihistamine, they're not going to respond to any special combination you might concoct in the clinic. They either respond or they don't respond. So if they're not responding, sort of move on. And very common, 1 in 2 patients aren't going to get better. So one of the therapies that sort of transformed how we took care of urticaria was Xolair and Omalizumab. A lot of people in dermatology don't use this medication. I'm going to try to help you with that because they're afraid of the anaphylaxis. But I'm going to teach you a couple of things about this. One is this is an anti-IgE antibody. So remember the mechanism I just taught you. IgE can activate the mast cell receptor. So this medication blocks the ability for the IgE antibodies to get in there and activate the mast cell. This has the same indications, some of the same indications as Dupixent, which makes sense, right? Because these are kind of those allergic type patients. But this is really a powerhouse medication. So I'm going to kind of cruise through this part a little bit, because when we're talking about a complete response rate, complete response, these patients, this is kind of like the PASI 100 of urticaria, 76%. So this is a medication that's better than any of the best drugs we have in any other field. We don't have a drug quite yet that at early time points have a PASI 100 of this size. We're getting really close. But the point is, in an analogous way, Omalizumab or this medication really has probably one of the best success rates we've ever seen. And so this is a medication, if you're not using it, can be extremely helpful. I used to use, all the patients that I ever saw, we would use this medication, and most people get better pretty quickly, actually. It's very easy to use. I'll just note that we typically don't use 150 milligrams. We almost always just start at 300. You usually have to go up there anyway, and oftentimes we might push it to 600 if we need to, which is off-label, but want to note that. Now, for the anaphylaxis, if those of you are here concerned about that, this is 0.1 to 0.2% of patients. It only happened in asthma patients. Asthma patients have a higher rate of anaphylaxis. Anaphylaxis did not occur in the urticaria trials, which is a really, really important point. Interestingly, when the patients we'd give omalizumab, we'd issue the EpiPen with it, which per the recommendations. I've had lots of patients use the EpiPen, but they never used it for omalizumab. They used it for like a peanut allergy or some other sensitivity. So really interestingly, every time I've given the patients EpiPen, they've never used it because of an injection. I've actually never seen this. I don't know a clinician who had a patient who got an injection in the clinic actually experienced anaphylaxis. So this was really in the asthma space. So really important to not avoid it for that reason. I'll end with this, which is sort of my call to action, which is that this is a skin disease. We are dermatologists. We can treat these patients. Don't be afraid of them. We have a lot of great therapies.
Thank you for listening to the Future of Dermatology podcast. Remember to hit that subscribe button and share the podcast with your friends. The more you share and subscribe, the more we'll be able to grow and share our dermatology knowledge. If you have burning dermatology questions, feel free to leave them in the comment below, and we would love to address them in a future episode. And please note that this podcast is not intended to substitute for medical advice from your doctor.